So good morning, good afternoon, everyone. Welcome to our Canadian MPN Network virtual patient conference. We would love to welcome you from coast to coast to coast, regardless of where you are. I know some of you are joining us from early in the morning out west to later in the morning or early afternoon out east. My name is Cheryl Petrick, and I'm happy to welcome you to our conference today. Right now, I would like to introduce Kristen Hummel, our Vice Chairman of the Canadian MPN Network, and she will be introducing our first guest speaker today. So sit back, relax. I hope you have a coffee or tea in hand and you enjoy our virtual conference today. Over to you, Kristen.
Thanks so much, Cheryl. Welcome everybody today. We're so glad to see such a large number of people could join us for our conference. I have the pleasure of introducing our very first presenter. He is Dr. Raajit Rampal, who will speak to us about the state of MPN treatments and what MPN patients can expect around treatment options. There will be a time for questions and answers following the presentation. Just some housekeeping, a friendly reminder to use the Q&A button, not the chat button, to submit questions. Do your best to keep your questions somewhat general in nature, as this makes it easier for Dr. Rampal to answer them, and also it applies to other people. And yeah, with that, I'm going to just do a little bio intro here for Dr. Rampal. Dr. Rampal is a hematologist oncologist who specializes in the treatment of myeloproliferative neoplasms in leukemia. He is the clinical director of leukemia services at Memorial Sloan Kettering Cancer Center in New York. His research focuses on elucidating the genetic events that contribute to the development and progression of myeloproliferative neoplasms and clinical trials of new investigational agents. So welcome, Dr. Rampal. We're so glad to have you here.
Thank you so much. It's a pleasure to be here with you. I'm glad to see there's so many people in attendance. And I hope I can convey some major points. It's also great to be with the Canadian MPN Association. As I have a special fondness for Canada, as somebody who grew up on the border and whose media intake growing up was as much the CBC as any American network. So I'm going to go ahead and share my screen. So I'm going to talk I'm going to do a really broad overview of current treatments for MPNs across ET, PV, and MF. And there's going to be a lot of detail here. And the point is not so much to get bogged down with the details, but really to give everyone a sense of the overview, knowing that there's people here with different diseases. But for everybody in the audience, there are two major takeaways. If you remember nothing else from what I tell you today, I want you to remember these 2 points. Number one, when we talk about treatment, what is the overall goal for MPN patients? The overall goal for MPN patients is to help patients live the longest life possible with the best quality of life possible. That is sort of the beginning of everything, right? And that has to be the mindset when we talk about whether to treat or not to treat. No matter what we do, if we talk about treatment or transplant, this has got to be the way we think about things. So that's point number one. Point number two is that we're on the verge of an unprecedented change in how we treat MPNs. And I think that, you know, as I train our hematology fellows, this is one of the key points I make to them, that what I'm telling them now is about to completely change, I think, within the next 3 years or so. And I'll talk a little bit about that today. So those are the two big takeaways from my talk today. So what we're going to do is I'm going to talk about ET and PV and what are the current concepts and treatments, and same for myelofibrosis, and we'll get into some of the novel things that are going on. So with regards to MPNs, right, just starting on a high level, MPNs are broken down into groups of diseases like myelofibrosis or polycythemia or essential thrombocythemia. There are another group of MPNs that are what we call BCR-ABL positive, and that is the family of CML, which is not what we'll be discussing today. But in that regard, right, we put diseases into little convenient buckets But the reality is that these diseases have a degree of overlap, and they can transition. So yes, it's good to classify, and we do our best to classify, but it's number one, not always possible. Number two, it's always important to remember that things can transition. So people can rarely be, for example, diagnosed with essential thrombocythemia, and it can evolve into polycythemia vera. Not a common thing, but it happens. Both polycythemia and ET can evolve into myelofibrosis, and ultimately all three can evolve into leukemia. So this is, it's always important to keep in mind that things can transition from where they are. So let's start by talking about PV and ET. So we'll start with polycythemia. So what is polycythemia and what do we worry about, right? So the symptoms of polycythemia include pruritus and fatigue and shortness of breath and dizziness, and sometimes the spleen gets enlarged as well. But there are cardiovascular complications, and that's one of the things we worry about the most. So there can be clotting events that are arterial, like a heart attack or a stroke. In the venous system, that's like a deep vein thrombosis or a pulmonary embolism. And people can have clotting in really unusual places, like in the circulation of the intestines and the abdomen. So thinking about what are the major concerns with PV, well, the disease can turn into leukemia. The reality is it's not a very high risk, but it is a risk. It can turn into myelofibrosis, and again, that's about 6% at 15 years. But thrombosis is the biggest thing. It's 27% of patients at 15 years. Now, this is somewhat older data, and if that's true in the current setting is not so clear, but either way, that is the biggest thing that we worry about, and that's what drives what we do. Skip that. And in terms of essential thrombocythemia, the symptoms are a little bit different. So people can have what we call microvascular complications. And that may be due to things like that's manifesting as sort of numbness or tingling in the hands, blurry vision, headaches, migraines typically, dizziness. More rarely people have constitutional symptoms, and these are things like night sweats and weight loss. It's not very common in ET, but it can happen. And spleen enlargement also not common in ET, but it can happen. So with ET, we worry about cardiovascular complications as with PV. We worry about bleeding, which can occur paradoxically as the platelets get too high. So instead of, one would think naturally that as the platelets get higher, there's an increased risk of clotting. But as it turns out, as the platelets get higher, there's actually an increased risk of bleeding, and there's reasons for that. And so when we break down what are the things that complicate the outcomes of ETs, leukemia, only 2% at 15 years, so not really common. Myelofibrosis, less, 4%. But again, thrombosis is 17%, right? So again, everything comes down to this idea of thrombosis. Now, we don't want to minimize the risk of progression in ET. And, one of the problems is when we say, well, there's a 8% or 2% risk of the disease progressing if you have ET or PV, it very much matters whether or not you are in that 8% or in the other 90%. And so it's kind of a hard thing to say to patients in general, well, this is the X% chance the disease can progress. And we need to get better at kind of drilling down who are the actual patients who are at risk of progression versus those who are likely going to have an indolent course for the rest of their lives. And that is what is being worked on by a number of groups. But some data we have currently gives us some sense of that, which is by using genetics. And from the genetics, this is for ET, for example, we know that certain mutations, which I've listed here at the bottom, are actually the ones that are associated with a worse prognosis. So, if you look at, let's say, the bottom graph, the panel C, this is the incidence of myelofibrosis-free survival. The people who have these mutations are much more likely to transform to myelofibrosis, whereas the people on the blue curve have kind of a relatively lower chance, right? If you kind of look at this at 15 years, 80% of the people studied here didn't have myelofibrosis, so they did really well. But if you look on the red curve, you're about 50-50, right? So 50% of those people progress to MF. And that is a very different thing than saying to somebody the risk is 4%, right? So we have to get better at drilling down at who are the people at risk, and the genetics help us do that. Now, what are our goals of therapy in both ET and PV? Well, The goals of therapy are to reduce the symptom burden, which really can be substantial, and to reduce the risk of thrombotic events, right? Those are the major goals of therapy. Now, as I just showed you, progression is a real thing, and we worry about that, but we don't really have tools at the moment that allow us to intervene and prevent progression. That is one of the major things, major goals that has been undertaken by the MPN Research Foundation, which is we are trying to figure out whether or not we can figure out who are the patients at risk and how do we intervene. And that's going to take a couple of years at least, but that's an important question. Either way, right now our goals are to reduce symptoms and reduce the risk of clotting. How do we do that across both ET and PV? We use things like phlebotomies for PV. We use aspirin for both ET and PV. Lifestyle modification. This is important, right? When patients ask, what can I do to help myself? Lifestyle modification is one of the things. And what does that mean? That means that anything that puts one at risk for having a cardiovascular event. So having hypertension, diabetes, high cholesterol, living a sedentary life, smoking. These are all things that magnify the risk of having a clot if you have one of these diseases. And those are things that you can do something about, right, to some degree. And so making sure that, one thinks carefully about how you're living a life, and also maintaining a close connection with the primary care doc is really important. And then finally, there's therapeutics. So things that we use to reduce the blood counts, which we think reduce the risk of clotting. And those are drugs like hydroxyurea, interferon, anagrelide, ruxolitinib or Jakavi, and in some rare cases, busulfan. So let's start by talking about ET. The way we approached ET a few years ago was to say, people were either low risk or high risk. And if they were high risk, we would put them on medications and aspirin. And if they were low risk, we would just put them on aspirin. But now that has actually changed with genetics. What we know is that in ET, there are 3 mutations that cause the disease principally. And that one of them, the calreticulin mutation, is actually associated with a lower relative risk of thrombosis versus JAK2 mutations or MPL mutations, or JAK2 mutations in particular. And so now we stratify people into 4 risk groups: very low risk, intermediate risk, and high risk. And that has to do with their age and the mutation that they have. But that has implications for treatment, meaning that we really only put people on treatments like medications, for example, if they are high risk. Anybody below high risk doesn't necessarily need medications unless they have symptoms or there's some other complications. For most people, we also use aspirin for high risk, intermediate, and low risk. But for very low risk patients, they may not even need aspirin. So treatment starts by first asking the question, what is a patient's risk of clotting? And then assigning a treatment based on this, as well as how the patient is doing overall. So what are the drugs that we use? We use principally for people who need treatment. So these are people who fall into the high risk category, hydroxyurea and aspirin, or sometimes people use anagrelide and aspirin. And the drugs work very differently. They've been studied head to head in one study. And hydroxyurea has really been the principal drug that has been used, at least in the United States, based on this study that was done a number of years ago that looked at what we call event-free survival, or the odds of not having a thrombotic complication, where it was 89% in hydrea versus 84% in anagrelide. I think, the curves are different and there is a difference in these numbers. On the other hand, it's not really that substantial. And so for that reason, anagrelide continues to be used to treat patients with ET, as does hydroxyurea. Now, a more recent study, or not recent, but more nuanced study, let's say, looked at this question again, because there are some controversies with regards to the diagnosis of ET and associated diseases. And in this study, there was actually no difference between anagrelide and hydroxyurea. So anagrelide is a drug that can cause palpitations. It can sometimes cause bone marrow fibrosis, but which is reversible if the drug is stopped. And that has been kind of the impediment to using it. But it is a very useful drug, and a lot of patients are on it and they do fine on it, and it is effective. But I think hydroxyurea tends to be the drug that is used most in ET these days. Other options include Pegasus or pegylated interferons, and this has been, of course, widely used in patients with MPNs, all MPNs, ET, PV, and myelofibrosis, and has a long track record of efficacy and safety. There are side effects that can occur with interferon, and those include things like depression or dysfunction of the thyroid, the liver. Rarely it can affect the lung function or the eyes, and so one has to use it judiciously. And it really is a little bit more challenging to use in older patients versus younger patients, but it is an effective drug and with a long track record. And here's a very an old study from 2009 that showed that if you look at patients treated with pegylated interferon who had ET, the number of patients who had a response was close to 80%. There are some with what we call a partial response, and so this gets the number closer to 85% or so. And it was really the minority of patients who didn't have a response to interferon. So interferon has shown itself to be really quite useful in patients with ET, and it can tend to drive down what we call the allele burden, or the amount of JAK2 that patients have in their blood over time, but that takes time to happen. So really an effective drug. What about ruxolitinib or Jakafi, which is a JAK inhibitor? And the JAK inhibitors are the things that the JAK pathway is really what drives all of these diseases. And so it's good to have specific drugs that target the pathway. And we have 3 approved, at least in the United States, for myelofibrosis, but ruxolitinib is one of those drugs that's approved essentially worldwide for the treatment of myelofibrosis. It has been studied in ET, which is logical since it's all driven by the same pathway. And what was done is this is a trial comparing ruxolitinib to best available therapy, which was mostly hydroxyurea treated patients with some other modalities used as well. And essentially, there was no difference in patients who got ruxolitinib or who got the best available therapy, which again, mostly was hydroxyurea, in treating their disease. There were no differences in the risk of having a blood clot. There was no differences in the overall response rates. There was some improvement in disease-related symptoms in patients who got ruxolitinib, and that's, I think, an important point. So this is not enough to lead to approval to the drug by regulatory authorities currently, but to me the data says that the drug works in people with VT, and that it might help their symptoms. And so it is a bit tricky to get access to the drug, but I think it is a drug that has efficacy. So really, to summarize ET, the therapeutic goal is to minimize the risk of thrombotic events. We stratify patients by genomics and clinical factors in terms of whether they need treatment. Low-risk low-risk patients can be treated with aspirin only, and patients who require therapy can have a number of therapies that work. There are new drugs in development. There's a class of drugs called an LSD1 inhibitor that is in clinical trials, and the data has been presented at a number of meetings that has shown that it can lower the platelet count in a sustained fashion. And so that is, again, an investigational agent that we will see if it ultimately gets approval to treat the disease. But that is something where this treatment may evolve in the near future. Now, moving on to polycythemia, we talked a little bit about the clinical features, but again, we worry mainly about blood clotting, but also the risk of progression. Now, the risk of progression, as we talked about with ET, depends to some degree on the genetics. And if you look here, this is the survival of patients with polycythemia. And if we stratify it by certain mutations like this one called SRSF2, or their blood counts or age or having abnormal chromosomes, it really does stratify people. And you can see quite clearly, right? If you look at 5 years from diagnosis, the group that we deem to be low risk by genetics, nearly everyone is alive and well, but in the higher risk group, you're getting into the 50% range. So again, comes back to the idea that we've got to do a better job of stratifying patients from the outset and saying certain patients are at very high risk of their disease progressing and others are not. Simply throwing out the statistic again that 9% of people will progress to MF at 15 years is, I think, increasingly becoming not useful. So aspirin is one of the central ways that we treat PV. As opposed to ET, there are some ET patients who don't really probably need an aspirin at all, but in PV, aspirin is central to treating PV. And we know that low dose aspirin is beneficial, and one does not need anything more than a low dose aspirin to help the disease. So the way we manage PV currently, and I think this is going to change, and I'll talk about that at the end of this section, is that currently we say people are low risk or high risk, and they're low risk if they're under 60 and never had a history of a blood clot, and they're high risk if they're over 60 and or have had a history of a blood clot. And we treat people with phlebotomy and aspirin if they are low risk, and if they're high risk, we give them medications, which we'll talk about, and aspirin. There are reasons to start treatment on therapy if somebody is low risk, if they have, progressive symptoms or a progressive increase in their blood counts. That's a reason to say to somebody who's under 60 that they may need treatment. But I will say that there is data now published in the last 2 years that actually looked at treating people who are low risk with drugs like interferon and asking if they do better versus if you just treat with phlebotomy. And it certainly does seem to be the case that, at least in a very small study, patients who were in low risk treated with interferon had better outcomes, at least in the short term. And there's also a bulk of retrospective data that has come from my colleagues across the street here in New York at Cornell, where they've looked retrospectively at a number of years of treatment of interferon and identified that treatment with interferon may actually significantly reduce the odds of fibrosis transformation, for example. And so we've got to ask the question, is this schema that we're using currently really relevant anymore, or should we start treating patients earlier on? To me, this is an open question, but it's a question that we need to address in the short term. So what about our current treatment strategies? Well, what is our goal? Well, our goal is to keep the hematocrit, which is the concentration of red cells, under 45%. And that came from this study where it was a randomized study of keeping patients' hematocrits greater than 45 or less than 45. And the group that was under 45 did better, significantly better in terms of their likelihood of being free of cardiovascular events or even staying alive. 45 is a line in the sand, but it doesn't tell us exactly where to be. Part of the issue here, of course, is that men and women don't have the same hematocrit at baseline. And so is it reasonable to keep men and women under 45, or should women be kept at a lower hematocrit? And there is evidence to support a number like 42%, which some people use as their threshold for phlebotomy. So more granularity is needed here, but at least we know there is a line in the sand, which we know clearly is associated with worse outcomes. Now, in terms of the arsenal of drugs that we use, it's very much the same as what I've talked about in an ET. So we have hydroxyurea, and hydroxyurea was studied versus phlebotomized in a retrospective manner, and there was a more thrombosis observed in patients who got phlebotomy versus those who got hydroxyurea. And this is a study from the dark ages of 1995. There was also people worry about the risk of leukemia with hydroxyurea, and because hydroxyurea is a DNA damaging agent, but to date we've not seen any large scale evidence that there is an increased risk of leukemia with hydroxyurea, which was shown in this study as well. So there are other factors that seem to contribute to it, but it's a point I wanted to bring up because I know patients are concerned about that. So what is the optimal treatment for polycythemia? We're still trying to figure out this question, as I alluded to earlier. But there have been some studies and some important data to be aware of. One is that there was a study called the MPDRC 112 study, which actually randomized patients with ET or PV to be treated with hydroxyurea or with pegylated interferon. And this was the readout at 1 year, which demonstrated that if you look at the response, and the response here is measured by the bone marrow and in the blood, the complete response rate in people who got hydroxyurea was 33%, and those who got interferon was 28%. It was not statistically significantly different. The same is true if you look in the PV cohort specifically, 26% with hydroxyurea and 19% with interferon. So there wasn't really a statistical difference between treating patients with Pegasus or hydroxyurea at 12 months. And that's the big caveat here. This is data at 12 months. So that data says to it, well, you could use either drug. However, in contrast, there was a study called PROUD PV study. And this is a study where they essentially took patients who either had not ever been treated and had PV, or had had hydroxyurea previously and were treated for under 3 years, and randomized them to a drug called ropeg interferon, or also known as Bezremi is the commercial name. And this is a longer acting interferon. So Pegasus is given every week by injection, and ropeg interferon is given every 2 weeks. And patients were stratified to hydroxyurea or to the ropeg. And interestingly, in the beginning, the data was sort of what we saw, what I just showed you with the MPDRC112 study, whereas if you look at the percent of responders, it was actually a little bit higher in the patients who got hydroxyurea, which is the green line, versus those who got the ropeg interferon in the red line. But a curious thing happened is that over time, the curves inverted. And so you started to see that people with hydroxyurea were losing their response, and the percentage of patients who had a response to the ropeg increased steadily over time. And now 5 years out, which is not the data I'm showing here, that those curves and those trends have held. So you do see a decline in hydroxyurea usefulness and a steady increase in ropeg usefulness. Now, that's something that's been known about interferons for years. They take time to work. This is not a drug that works in 3 months. It can take months to years to have a full effect. But the data from this study in particular has shown that over time, there's a sustained effect with the ropeg interferon. And these data led to the approval of ropeg interferon by the European Medical Authority, as well as the United States FDA. And so now this is considered a first-line treatment in the US for patients with PV. So patients who need treatment can go on ropeg interferon up front, and there's data to support it from the study. Hydroxyurea remains a drug that is utilized frequently, and it is a reasonable thing to do. And one thing to remember with this study is they only looked at blood count responses. They did not look at bone marrow responses. And so we don't really know if the bone marrow changes over time, but we do know that the blood counts are under better control. The question really is now, should any patient be treated upfront with a drug like ropeg interferon? Should we take our low-risk patients and treat them rather than just phlebotomizing them and giving them aspirin? And again, there's some data to support that idea, but we need to explore that further because it may completely change how we treat PV. What about ruxolitinib? Well, ruxolitinib has also been studied in this setting, and ruxolitinib was studied specifically in people who have been on hydroxyurea, but either had a complication from their treatment or had insufficient control of their disease. And the study looked at 2 things. It looked at control of the hematocrit as well as reduction in the spleen size, because the spleen size is often increased in people with polycythemia vera. And overall, a couple of things to look at. If you look here at the far right, hematocrit control was achieved in 60% of patients who got ruxolitinib and only 20% who got other therapies, most of which was, again, hydroxyurea. And the same thing was true in terms of reducing the spleen size. So furthermore, if you look at symptom profile, and these are the percent of patients with a 50% or greater reduction in their symptom scores, it was clearly higher in patients who got ruxolitinib, which is in the orange, 49%, versus 5% of those who got treated with other modalities. So it really based on the hematocrit control and the spleen volume. The drug was FDA approved in the US, I think, in 2013 or so, and is widely used in patients who have been on hydroxyurea. So ruxolitinib is a very useful drug in polycythemia vera. And the data 5 years out in patients in this study shows that about 70% of patients who were put onto ruxolitinib were able to stay on ruxolitinib. So it is having a sustained effect in patients treated with polycythemia. So again, just to recap with PV, in first line, low risk patients, currently we use aspirin and phlebotomy. And, phlebotomy is a centuries-old intervention. I think it may be time for this paradigm to change, and for us to get out of the 3rd century and start doing things that may be more effective. We're not there yet. We need more evidence to support that, but I think the evidence is beginning to accumulate. For first-line therapy, ropeg interferon, at least in the US and in the European Union, is approved, and ruxolitinib is available in the 2nd line. So we have a number of useful and medications that have efficacy in this disease. There is upfront data emerging with a new drug called rusfertide. And rusfertide is actually a really interesting and cool drug in the sense that it doesn't work like a chemotherapy. What it actually does is it prevents the utilization of iron, essentially, when building red cells, and that's part of the component of making hemoglobin. And the early studies that have been presented so far with hepcidin have shown that it is able to markedly reduce the phlebotomy requirement in patients who require phlebotomy. Currently, it's in phase 3 trials, and it's a randomized trial where half the patients essentially will get rusfertide, the others will get phlebotomy. And if that trial turns out to be positive and that drug works well, it has good safety, and it works in terms of reducing phlebotomy, that may completely change the paradigm of how we treat polycythemia vera, and maybe we start to part ways with phlebotomy as a tool. So the last section I'll talk about is myelofibrosis. And myelofibrosis is characterized really by bone marrow fibrosis and an enlarged spleen that can cause a number of different symptoms. And the course can be quite complicated, and it takes multiple different directions in different patients. Patients can have debilitating symptoms, and these things include night sweats, unanticipated weight loss, feeling full early, fatigue, which is the #1 symptom patients have, body aches, bone pain, and so patients can have a really impaired quality of life. That's important for us to always remember. It can cause the spleen and the liver to get markedly enlarged. Over time, it can cause the blood counts to fail, so the people become dependent on red cell transfusions. Patients become dependent sometimes on platelet transfusions, and ultimately can lead to leukemia. And so this, to me, is really, of the 3 diseases, the one that has the most unmet need and can have the most severe complications. How do we treat MF? Well, the answer to that question is it depends on what the issue is. For things like anemia, if somebody has only anemia and they have symptoms from anemia but no other issues, there are drugs that are ancient that we can use, like thalidomide or steroids, or what we call erythropoietin stimulating agents, which are injections. But for people who have symptoms, the debilitating symptoms, or have an enlarged spleen, the mainstay of therapy are JAK inhibitors. And there are 3 approved in the US currently: ruxolitinib, fedratinib, and pacritinib, which isn't on this particular slide, but I'll show data regarding that. There are other things that people have used. Interferon has been used in early MF, but it's really early MF. Sometimes radiation is utilized, and sometimes chemotherapies can be utilized if patients have more advanced disease. Now, interferon, I won't spend too much time here. It has been studied in a number of small studies, and the bottom line here is that it seems to be beneficial in people with very modestly enlarged spleens. So early phase disease, it can have benefit in terms of improving blood counts and bone marrow function, but not so much in later phase disease. In later phase disease, ruxolitinib and other JAK inhibitors have been the mainstay of therapy. And this was based on 2 randomized trials, both in the US and Canada, as well as in Europe, where patients who had MF and who were never treated before got either ruxolitinib or placebo or some other available therapy. And the bottom line takeaway is that in patients who got ruxolitinib, their spleens shrunk much more than what was seen in patients, for example, who got placebo, 41% versus 0.7%. This number refers to the percent of patients who had a 35% spleen volume reduction. That doesn't mean that everybody else didn't have their spleen shrink. It was just if they met this particular cutoff. But really importantly are the symptom reductions. And you can see here in orange is ruxolitinib. The majority of patients had reductions in things like itching, night sweats, feeling full early, abdominal discomfort, inactivity, right? So the drug does substantially important things in terms of symptoms. Another important point, which is not always appreciated, is that when this data from these two studies was pooled and they looked at survival, it turns out that people treated with ruxolitinib tended to have a better survival than people who didn't get the drug. So the risk of death was reduced by 30% in patients who got ruxolitinib. And the median survival in people who got ruxolitinib was 5.3 years versus 3.8 years in those who didn't, right? So we come back to the central idea that I talked about at the very beginning. We want people to live longer, we want them to live better. And clearly we've gotten somewhere with our JAK inhibitor therapies. Other JAK inhibitors are improved. There's a drug called fedratinib, which was studied in what's called the Jakarta study, where people got placebo or they got fedratinib. And the same sort of things were seen as I showed you with ruxolitinib, right? So if you look at the proportion of patients who got this 35% spleen reduction, it was 36% or 40%, depending on the dose of fedratinib that was used, but it was 1% in people who got placebo. So that was really significantly different. And if you look at the symptom score over time, in placebo-treated patients, it doesn't change, but in patients who get fedratinib, it decreases over time. So again, same idea, spleen gets smaller, symptoms get better. And finally, there was pacritinib, which also was studied in patients either who have never been treated before or people who have been treated before. But the difference with pacritinib is that it was studied selectively in patients who have low platelets. So the PERSIST-2 study in particular looked at patients with under 100,000 platelets. And in more recent studies of pacritinib, the platelet count of less than 50,000 has been looked at. And that is an unmet need because both fedratinib and ruxolitinib are not approved for patients with a platelet count of under 50, which is a very challenging scenario. And so essentially the same pattern as I had shown you before, whereas spleens shrink much better with pacritinib versus best available therapy or alternative therapy, and symptoms improve much more in patients who get pacritinib versus those who get other therapies. But this holds true in people with really, really low platelet counts. Patients with platelets under 50,000, where you see the same thing. The spleen gets better and the symptoms get better. So even in a group of patients who have very challenging blood counts, the drug works for them and it improves their lives, I would say. And for this reason, this was given accelerated approval in the United States. So now we're able to prescribe this drug in the US, and it, I think, is, in my opinion, has made a difference. So this is all good. It's great that we have 3 JAK inhibitors. I think they are making a real difference. But we have to keep in mind one important aspect here, which is that the drugs don't have a long-term effect and they don't modify the disease. These are not curative therapies, right? Do they make life better? Yes. Do they potentially prolong life? Yes. But not enough, in my opinion. And we've got to do better. If you look at the probability of somebody staying on ruxolitinib, for example, over time, all you have to do is look at the curve and see that it goes down steadily over time, right? People either have a side effect or they lose a response to the drug. And we're beginning to understand why people lose response to the drug. And so we've got to do better. We've made a significant advancement by having these drugs available, but we've got to do better for MF. And so the last slide in my talk that I'll leave you with, which I think is maybe the most optimistic slide, which is to show you that this is where we are today. We have a number of new drugs that are in development, in late stage development for patients with myelofibrosis. There is a drug called CPI-610, also called pelabresib, which has generated a lot of excitement. It's in phase 3 trials, and it's being studied in combination with ruxolitinib. It has been studied in earlier phase trials, in phase 2 studies, and it looks like it reduces the spleen by about 70% or so in patients versus the 40% with ruxolitinib alone. There is a drug called navitoclax, which is a BCL-XL inhibitor, and that's being studied up front in patients who have never been treated in combination with ruxolitinib or in patients who are already on ruxolitinib. There's a drug called parsaclisib, which is also in phase 3 trials, which is being tested in addition to ruxolitinib. A drug called imetelstat, which is being studied without a JAK inhibitor. Bomedistat, which is an LSD1 inhibitor, which I mentioned was being studied for ET. KRT-232, which is an MDM2 inhibitor, AVA200, and another JAK inhibitor called momelotinib, which may be able to actually improve anemia. So, for a rare disease to have such an array of new drugs in late stage development is really exciting. And this is why I'm very confident that we are going to be able to do better for this disease. Number one, that we're going to change how we treat these diseases in the very near future. So I'll conclude with that, and I'm happy to take any questions.
Terrific. Thank you so much, Dr. Rampal. We do have a number of questions, so I'm just going to go to the Q&A here. The first question is, curious to know, on average, how long does it take for patients to see a response with interferon?
It depends. I mean, you can see responses, in 3 to 6 months in some subset of people, but in some people, it'll take more than 12 months to have a sustained response. Part of it seems to be related to how early their disease is. So in other words, in people who have a low amount of the JAK2 mutation, we actually see improved responses, whereas in people with the higher amounts of the JAK2, we may not see as much of response early on. So it is a range.
Our next question here is, how important do you think NGS is for all MPN patients, and why? I think that refers to next generation sequencing.
Yeah, I think in 2022, it is absolutely the standard of care. We must get genetic data on every patient because, as I've shown you today, right, in ET and PV patients, it is beginning to tell us who are the people who are really going to be at risk for having a bad outcome, for having a progression of their disease. But also in MF, and I didn't get into this in my talk at all, the genetics are immensely useful in predicting who is going to be at high risk of their disease progressing. But the other point here is that some of these mutations are targetable. There is a mutation called IDH2, for which there is an FDA-approved drug to target that specific mutation. And it does occur in people with more advanced myelofibrosis. And as it turns out, we've got a clinical trial now where we're giving Jakafi plus an IDH2 inhibitor. So it's important for prognosis. It's important for planning treatment. It's important potentially for giving novel treatments.
Great, thank you. All right, our next question is, how long does a doctor monitor the symptoms until progression has been confirmed?
It's an interesting question. I mean, it's one thing I will say is that we don't have a standardized definition of progression, and that's problematic, and it's something we are kind of working on. Because what does that mean? Does that mean that the blood counts get worse? Does it mean the symptoms get worse? I would say any or all of those things. I think it has to be sustained. And what does sustained mean? Well, it could, certainly mean that it is occurring, twice over a 6-week period or over a 3-week period. But I would say that if it's a sustained change, I would characterize that as a progression.
Thank you. Let's see what the next question is here. Okay, we have one that says, if the mutation rate decreases, does it mean the disease is going in the direction of healing? And is there any research or method to prove it's possible to decrease the mutation rate?
I guess my guess is that probably refers to the JAK2, what we call the allele burden, or the amount of the JAK2 mutation. Yes. It's an interesting thing in the sense that the amount of the mutation, or what we call the variant allele frequency, right, correlates to some degree with the severity of the disease, meaning that people with a really high number are more likely to have PV or myelofibrosis and much less likely to have ET. But does decreasing it make a difference in terms of improvements? The answer is yes and no. From a biological perspective, right? If we eliminated the mutation completely, would that likely lead to resolution of the disease? I think the answer is likely yes, because that's what happens when we do a bone marrow transplant and it's successful. On the other hand, most of the drugs that we have only modestly decrease the amount of the mutation, right? It may go down by 20 or 30%, but it doesn't really go away to a point that I think is likely biologically and clinically significant. So the broad answer is yes, eliminating the mutation will likely have a substantial effect on reversing the disease. but the drugs that we have currently aren't, at least to at the moment, showing that they're able to do it in such a meaningful way. Kristen, you're on mute. You're still muted.
Sorry, I put myself on mute because someone just decided to mow the lawn right outside my window. My apologies. I'm going to close that window in just a second. All right. Is there, next question is there a known relation between ET and high RDW? I don't know what RDW refers to, but perhaps you do, Dr. Rampal?
I think it's probably referring to the red cell distribution with, not really. So the RDW, we see it get larger in people, for example, with iron deficiency. And so, yes, sometimes it could be related to ET or if someone has iron deficiency or PV. And sometimes it can be related to drugs like hydroxyurea, which actually increases the size of the red cells. And so the RDW looks at the spectrum of the red blood cell size. So hydroxyurea does increase the size of the red blood cells. And so, yes, that could be the effect, not so much the disease itself.
Okay. Wonderful, thank you. The next question states, is there any case that HU and interferon are used together at the same time?
Yeah, they can be. Sometimes we have trouble getting control of the disease quickly. We talked about timing and interferon. And so, for example, sometimes we start somebody on interferon and it's just not working quick enough. We can give them or add in some hydroxyurea just to kind of temporize the blood counts as we wait for the interferon to have its effect.
Okay, the next question here says, does phlebotomy have a frequency guideline to determine if we need to take the drug? And there's a bit more detail, but I think that kind of sums up what we're looking for here.
I think the answer is yes. I mean,
Okay.
we want to try to keep phlebotomy to a minimum. Ideally 3 times a year would be best, but there is too much frequency. Because the thing is, phlebotomy is not a benign thing. Phlebotomy causes iron deficiency, which can cause symptoms, but phlebotomy and iron deficiency are associated with something called pulmonary hypertension, where the heart has to work harder to push blood into the circulation in the lungs. So one does not, yes, so I guess the bottom line is we try to maximize our treatment in order to minimize the phlebotomies if we can. And it depends on the individual. Some people just cannot tolerate phlebotomies so frequently. So it's both clinical, but also how the patient's doing.
Okay. Terrific. The next question is, how important are blast cells percentage in progression of PV to MF?
They are important. I mean, you can sometimes see blast cells in the circulation in people who still have chronic phase PV, but if they're sustained and going up, then we really get concerned that the disease is transforming to MF or sometimes even AML. We look at 2 things. We look at the bone marrow blasts and the blood blasts. And so, there is you do tend to see higher blast counts in general in MF. Not everybody with MF has higher blast counts, but if somebody is starting out with PV and that number is going up, it's time to reinvestigate whether they're still in PV.
Great. Okay, the next question here is, do we have any data on the COVID-19 antibodies retained in PV patients?
Yeah, that's a really important question, right? So a number of groups have studied this, and we've studied and published on this too, because we were worried about this issue. It does not look like the diseases in themselves impair antibody formation in response to the COVID vaccines. So that's the first thing. The second thing is, well, what about the treatments? And we've not been able to identify that the treatments decrease the likelihood of response to the COVID vaccines. In fact, from our data at least, and I think one other groups, the patients on interferon may actually mount a little bit of a higher antibody response in relation to the COVID vaccine. So it doesn't look like that our MPN patients are affected to a great extent by treatment with current therapies.
Okay, thank you. We've got here, is low risk PV okay to use Pegasus if you get a good response?
I think that's an important question, because I think the question has to be, shouldn't we consider using Pegasus or interferon in even low risk PV patients? And there is data to support this idea, not with Pegasus so much, but with the Ropeg interferon, which, at least in a very small study, did show that it may actually improve outcomes versus just treating people with phlebotomy. So I think that if there's a rationale to treat, right, if somebody's having a lot of phlebotomies, or they're having symptoms, or they can't tolerate phlebotomy, it is a reasonable thing to treat with a medication. It is a reasonable thing to treat with interferon.
Okay. Regarding ruxolitinib, what are the main adverse side effects that people on it will experience?
Sure, we can break that down into two things. Ruxolitinib can have effects on the blood count. So typically it causes anemia and it causes lowering of the platelets. That is those are both very common side effects. Beyond that, there is some increased incidence of viral reactivation, so things like shingles or zoster. And so it's important that people, if they're eligible, get their zoster vaccinations before starting on ruxolitinib. It can cause reactivation of other things like latent tuberculosis, and so we oftentimes will check people for latent tuberculosis before we start a JAK inhibitor like ruxolitinib. And aside from that, then you're getting into very rare side effects that can rarely cause not rarely, but in 20%, I think, or less, cause gastrointestinal side effects. In general, the drug is really well tolerated, but you have to watch out for the blood count effects and for the infection issues.
Okay, thank you. So the next question states, how would you treat a person who was diagnosed originally with a JAK2 mutation and since is, and my apologies, I don't know what this means. Oh, I just got the answer. CALR mutation positive with no JAK2 mutation detected in blood or bone marrow.
Yeah, so this is an interesting thing, because the textbook says you either have one mutation or the other, and the textbook is wrong. Because we see patients have both mutations. Sometimes it's not a common thing at all, but we are actually trying to put some data together on this. So you do see people with both mutations rarely, and sometimes what happens is one of them is what we call subclonal. So let me put that into easier to understand terms. Usually what happens when people have two mutations like this, if they have both a JAK and CALR, one of them is extremely low, like at the verge of being undetectable, and the other one is sort of more prominent. And over time, the one that is extremely low will kind of fade away, and the other one will just kind of take over prominence. Why that happens is we don't really know the answer to that. So it doesn't really change management per se that we're aware of. We would probably still treat it the same way depending on what the underlying diagnosis is, but it does happen.
Thank you. We've just got a couple of questions left here. Someone would like to know, can spleen enlargement be apparent on physical examination but not show on the ultrasound? Which is interesting.
Not likely. I mean, granted, ultrasound is very much dependent on the person doing it. And so, could somebody have a subtle increase in their spleen size and the operator doesn't pick it up for whatever reason? I suppose it's possible. I don't think it's likely. It certainly isn't likely at all with, something like a CT scan or an MRI, because those are, it's hard, those are not so much operator dependent scans.
Okay.
So I think it's not likely.
Okay. And this is going to be our final question, even though those questions are coming in fast and furious. Are there any different approaches for PV patients that are 45 or younger with thrombosis? We don't seem to align in the studies presented.
You're right. I mean, again, this is this situation where the textbook says that most people with PV are, over 65. It's just, I don't think that's true. I have many patients under the age of 40 who I treat. And I think that we are applying our treatment algorithms for older patients to younger patients. Should that be the case? I don't think we know the answer to that. We need more data here, right? We tend to, with the same principles would apply in that we put people on medications to lower the counts, like interferon or other drugs. And we tend to put people on lifelong anticoagulation. But the problem that's relevant here is lifelong anticoagulation means something very different if you're 45 versus if you are 70. And should that be the case? Can it be stopped? We just don't know the answer to that right now.
Terrific. Dr. Rampal, thank you so much for being part of our conference today. I think everybody found it extremely informative, and I really thank you for your time.
My pleasure. Thank you for having me.
Thank you. And Cheryl, I'm going to pass it back to you now.
Thank you so much, Kristen. And thank you, Dr. Rampal. Very, very enlightening talk, and always a pleasure to hear our MPN doctors speak and provide our patients with such great information. And I too believe that it is very optimistic. It's a very optimistic time for our MPN patients today to have a lot of hope, inspiration, knowledge, and education regarding their disease. So thank you once again. At this time, I'd like to thank our sponsor, Novartis, who has contributed a great deal of time and effort and patience and support to the Canadian MPN network in helping us achieve our endeavors and help our patients learn, share, and grow and prosper with our organization, and helping our patients support in helping our patients be supportive of their education and knowledge and understanding of the disease that they have been diagnosed with. So at this time, I would like to we have a video presentation from Dr. Pierre Villenueve out of our Ottawa hospital. Pierre is a MPN hematologist and works with the hematology department in the Ottawa region at our Ottawa hospital. And at this time, we will have his video presentation presented. And if there are any questions from his video presentation, please do put them in the chat, and we will forward them to Dr. Villenueve for reply and post our answers on the website for you to have those answers. So now we'll listen to Dr. Villenueve and his recorded presentation for us.
Good morning, everyone. My name is Dr. Pierre Villenueve. I'm a hematologist at the Ottawa Hospital, and it is a pleasure to give this talk. I've been asked to provide an overview of the clinical trials that are available in Toronto as well as Montreal and in Ottawa on myeloproliferative neoplasm. So the objectives are as stated here. So first, I will provide some very brief overview of the care of MPNs, but also identify the unmet needs, and then I will dive into the different clinical trials, and I've categorized them into 4 different categories. So trials that are interested in finding better ways to prophylax or prevent vascular complications in patients with MPNs. Second, trials that look into ways to cytoreduce the counts of patients who have essential thrombocythemia or polycythemia vera. And then third, the optimized management of patients who have untreated myelofibrosis. And fourth, the new drugs for the management of patients who have myelofibrosis, and who have failed Jakavi. So although MPNs were discovered now almost 150 years ago or so, there is the evolution for the treatments have been very, very slow. And it's only about in 2005 that things started to unlock, because then we discovered a mutation, the JAK2 mutation, that led to the development of a molecule called Jakavi that targeted that mutation. And in 2011, the FDA released, and then Health Canada soon after, Jakavi, and since then has been used for the management of patients who have myelofibrosis and sometimes also polycythemia vera. I think at this point I would like to take a few seconds just to highlight what are the needs, and also maybe what are where we're at in terms of management of ET and polycythemia vera. So the 2 big problems, the 2 most common complications are on the left the thrombosis, and then the other that patients have. So patients are very high risk of thrombosis and they have high counts. They're related, but in terms of management, we use currently aspirin for the prevention of vascular complications. But there's some suggestion that we're not doing well enough. So there's still some people who have clots that happen while being treated with aspirin. So there's a drug that is not a new drug, but it's just a new indication called apixaban that has a very different mechanism of action that seemed to at least has the potential to be maybe more effective, or at least equally effective compared to aspirin for the prevention of blood clots. The other aspect of the management of ET and PV is, of course, cytoreduction, and we have drugs that lots of you will be familiar with, so annuelle, hydroxyurea, sometimes busulfan, and Jakavi can be used. But in terms of new drugs, so these drugs have limitation, toxicities, and they don't change the natural course of the disease. They don't prevent transformation into fibrosis. They don't prevent transformation into acute leukemia. They don't control lots of the symptoms. So there's a drug called interferon that is actually a drug that mimics cytokines or molecules that we produce in our body, especially when we're sick, when we have an inflammation. So pegylated interferon is just another form of interferon, and it seems to not only be effective at cytoreducting, that means controlling the blood counts, but also at reversing lots of the processes that are happening in PV and ET. Okay, so now that we've identified the needs, we're just going to move to the clinical trial. So the first one that I want to introduce is is the airport study. So this is actually a pilot study that is being run from Ottawa, and it's a randomized controlled trial that assesses the feasibility of thromboprophylaxis with apixaban in JAK2 positive MPNs. So the unmet need from the study is to optimize the management and the prevention, I should say, of blood clots in patients with MPN. So it is a pilot study. So what that means is that once we have completed this study, we'll apply for funding to conduct a broader scale study using multiple centers and at the international level. So the intervention is either apixaban, which is the drug we're testing. So it is, like I said, it's not a new drug, but it's a new indication. So it's a small dose of apixaban. So it is an anticoagulant, and we compare that to aspirin, which is the standard of care. The primary endpoint, given the fact that it's a pilot study, is a feasibility. In other words, we want to make sure that it's possible to conduct a study, that we've got the resources, and also that the patients are able to tolerate the drug and are being compliant. And the secondary endpoints are vascular complications. So these include DVT or deep vein thrombosis, but also myocardial infarction and pulmonary embolism. And it is a Canadian study, and like I said, it is based in Ottawa. The second study now is moving to the cytoreduction unmet need that I was alluding to just 2 slides ago. So this is a SURPASS study where pegylated interferon is being tested in this time in patients who have essential thrombocythemia. So to be enrolled in this study, patients have to have a diagnosis of essential thrombocythemia, they have to have high platelet counts, and they have to have never received interferon prior. And patients are randomized to either receive the pegylated interferon here or annuelle, okay? And then they're followed for up to 52 weeks, at which point they look for the primary endpoints, the study here is enrolling both in at the Jewish as well as Princess Margaret Hospital in Toronto. And the primary endpoint are what you would expect from ET study, so namely normalization of the blood counts, spleen normalization, along with a improvement in the symptoms. So lots of patients with ET will have symptoms such as fatigue, itchiness, sometimes symptoms related to splenomegaly, or they can have something called erythromelalgia. The other endpoint is thrombosis, of course. In terms of the another study that tests interferon, but this time for patients who have polycythemia vera. So the name of the study is Eclipse. So this one is a phase 3B, but it is a single arm study. So that means every patient who is enrolled will actually receive the drug. And the objective of the study is to assess the efficacy as well as the safety and tolerability of ropig interferon in patients who have PV. In terms of entry criteria, patients have to meet the diagnostic criteria of polycythemia, and they have to have not been treated with interferon prior, and patients will be treated up to 96 weeks. This is, like I said, a single arm study, and the goals are really to assess the tolerability and efficacy of pegylated interferon. And the study is open at the Jewish General Hospital with Dr. Siram. At this point, we're going to change gear. We're going to talk about myelofibrosis. So myelofibrosis is within the same spectrum of essential thrombocythemia and polycythemia, but more advanced. So patients tend to have a much bigger spleen. They tend to be more symptomatic. They tend to have more constitutive symptoms of fever, chills, night sweat, weight loss. Because their spleen gets so big, it compresses their stomach. So they can have some discomfort in their belly, some bloating, but also they have less appetite. We call that early satiety. So they may be losing weight, which will contribute further to the fatigue. Another aspect of myelofibrosis is that and that's where they derive their name, is that their bone marrow becomes fibrous or scarred. And as you can imagine, this affects the ability of the bone marrow to produce normal cells. They also develop anemia. So this is just a peripheral blood film. So take a sample of blood and look at it under a microscope, and this is anemic. So that means the patient doesn't have enough red cells, which are the little round structure that you see there. So looking into that, we can now just design a table where we can look at what are the needs and what are the drugs that are being used and what are the experimental drugs that are being tried before we actually introduce the clinical trials. So I've told you that patients who have myelofibrosis will have anemia. So we do have drugs that work for that. Erythropoietin limiting agents, or EPREX, is the one that we'll see most commonly used, but also steroids, danazol can be used. The problem is that invariably patients will stop responding at some point. In other words, the drug, the EPREX, will stop causing a rise in the red blood cell count. So there's other drugs that can be used, like thalidomide, lenalidomide, with some variable success. But the drug that is generating more interest is called lustapercept. So this drug has a very different mechanism of action compared to EPREX, and based on preclinicals, that means lab animal models, but also early clinical studies, seems to be able to generate the production of red blood cells even in patients who have failed EPREX. So that's very appealing because you can imagine that anyone who's severely anemic and needs transfusion, that affects your quality of life. You'll never have your full energy that you used to. So lustapercept is seen as a promising drug in that regard. The other symptoms that I've alluded to, of course, is big spleen or splenomegaly. So Jakavi works. So Jakavi, we'll talk a bit later, but it's a specific JAK2 inhibitor. It's very, very, very effective at reducing spleen size to some extent for some time, but some patients don't respond or don't respond as well. Also, Jakavi has some limitation that we're going to talk about. So it's always, so that has generated the interest to look for alternative drugs, such as navitoclax or pacritinib, as well as the pelibresib that I'm going to be talking about. Because like I said, every patient eventually at some point will fail Jakavi, so you need to think of what are the alternative when that becomes the case. Okay. So in terms of the anemia and that we see in myelofibrosis, so luspatercept, like I said, is thought to be effective. So this graph here, or this table, is just to show that patients who get treated with luspatercept do have an improvement in the transfusion independence. In other words, people who receive that drug need less transfusion compared to those who don't. Okay, and that has justified performing a clinical trial where the drug would be used in patients who have myelofibrosis. So this trial is called the ACE 536. Not very appealing name, nonetheless. I think an important trial because addresses an important need. So there's 4 categories of patients there. Those patients who have never received Jakavi or ruxolitinib versus those who have received the drug, and some of these patients are transfusion independent, so that means they don't need transfusion regularly, and then there's people who are transfusion dependent. So it's effectively 4 cohort or 4 different groups of patients, and all of these patients, so it's a single arm study, everyone receives the drug, which is an injection under the skin every 3 weeks, and then the patients are being assessed for response after 169 days. If they respond, they actually are allowed to continue for up to 3 years. And if they don't respond, then of course the drug is discontinued. So this clinical trial is open at both in Toronto with Dr. Gupta, as well as in the Jewish General Hospital with Dr. Siram. Okay, now how about the other symptoms that we often see associated with the myelofibrosis? So I've told you these patients have often a very big spleen, which affect their symptoms. They get anemic, of course, that we've talked about, but also they can get fever, chills, night sweat, decreased energy. So in other words, they can be quite miserable in some cases. So the drug Jakavi really changed the course of patients who have myelofibrosis. So there was a big study performed that was published in the New England Journal of Medicine that showed this is spleen size. Okay, what we see is that most people will have a very significant reduction in their spleen size. Very few, and these are here, don't have any spleen size reduction. Compare that to what was the best available therapy at that time, which was just steroids, hydroxyurea. So you can see there's very significantly better, and that's shown here in this graph where you see the spleen size gets much smaller. Okay, so the point is that because of this, it really is the standard of care. The problem, so Jakavi or ruxolitinib has got some good stuff. So improve all the symptoms that patients have, the fever, chills, night sweats. It can improve patients' energy, give them back their weight, and will improve the splenomegaly, but it is not curative. It does not, and it often causes worsening anemia or thrombocytopenia or platelet counts, so increase the risk of bleeding. It cannot affect, or it doesn't affect the risk of transformation to leukemia, and it doesn't affect the underlying bone marrow fibrosis. Okay, so in other words, it doesn't change the natural course of the disease in any way or form. So that's one of the these elements led a number of investigators looking for alternative drugs that, if you will, address the limitations that Jakavi has. Okay, so one of these drugs is pacritinib. So pacritinib was trial in the Pacifica trial. It is also a JAK2 inhibitor, but it's more specific than Jakavi. And one of the interesting things, so it's also, of course, for patients with myelofibrosis, but one thing that is interesting about this drug is that it doesn't reduce platelet counts. So patients who have much lower platelet counts are actually able to take that drug, which is very hard to do with Jakavi. The patient have to be symptomatic, so that's the DIPS score is just a measure of the level of how risky the disease or advanced, if you will, the disease is. The patient have to have an enlarged spleen and have some symptoms. And these are the TSS is just a score that we can use to measure score. Patient have to have a good performance status and have not received any Jakavi or fedratinib or any other JAK2 inhibitor. So this is a randomized study. Patients either received the pacritinib, it's a pill, versus physician's choice, and the primary endpoint is a spleen size reduction, and then there's a number of secondary endpoints that include symptoms and survival. So this trial is available both at the Jewish Hospital and the Princess Margaret Hospital in Toronto. Now, there's a number of other JAK1 and 2 inhibitors that are available at different sites, at least not in Ottawa nor Toronto, Montreal that I know of, but there's definitely an interest for drugs that have very different mechanism of action. The whole rationale of looking for drugs that have different mechanism of action are twofold. One is that you are not likely to have the same toxicity. So in other words, you don't have the same side effects because the drug is just so different. The second is that you may have different benefits. In other words, it can do things differently and even potentially work in patients who have been resistant to the JAK2 inhibitors. Okay, so one of these drugs that seems to be quite promising is pelabresib, or CPI 0610 when it was that's how it was first named. So it's a BET inhibitor. Okay, and it acts very differently. But what it does is it will affect the transcription. That means the production of proteins that have an impact on the number of cytokines. Cytokines are just the molecules that allow the communication in your blood. So when you have an infection, you have lots of cytokine, for instance. So that these contribute to make people feel very sick, people who have myelofibrosis. So this drug, at least in animal models, reduces the production of cytokines, reduces the production of red cells, reduces the production of platelets and megakaryocytes and collagen, which causes fibrosis. So it's thought that it has the potential, at least based on what we know, again, in animal models, to affect, to decrease the production of fibrosis and decrease inflammation, and hence probably make the patient feel better. So there's lots of trials that look into the use of pelabresib. Okay, it's been tried in different phases of the disease and in combination or alone. So in combination, typically with Jakavi. So here what I have is three arms. The arm A is for patients who have received Jakavi and who are refractory or intolerant. So some people have too many side effects with Jakavi. And in this study here, the drug, the pelabresib, is used as a single agent. That means just the only drug, and then it's patients are being treated, and then they look for transfusion dependence, spleen size reduction. In arm B, these are patients who have had a suboptimal response to Jakavi, and in this case here, the drug is being used with a Jakavi, so pelabresib and Jakavi. The rationale behind that is that they thought they may have a synergy of some form of way of working together that improves beyond the individual drugs alone. And the arm C is in patients who are never been exposed to Jakavi. And in this setting, the drug is pelabresib is being used with Jakavi. Okay, and this is the trial that we have currently available at multiple of the sites here, both in Ottawa, Toronto, and Montreal at the Jewish Hospital. Okay. Now, at this point, I would like to just change gear. I've told you that Jakavi has been the standard of care. It is the standard of care in Canada and in the US as first line. One of the problem with Jakavi that I did not talk about is that it always fails eventually at some point in time. Okay, so these are data from where they've looked at the percentage of people who fail over time. I believe this is from Princess Margaret Hospital, and they've have that about after 3 years, about 50% or so of people have discontinued the drug. Okay, so like I said, everyone eventually fails, and one of the problems is once you fail the drug, the prognosis, so in other words, the survival is affected. So patients who fail Jakavi, that's in red, survive less than people who are still on the drug. It's not surprising if you think of it, because often when you start failing your treatments because your disease is becoming more aggressive, but that translates in decreased survival, and that's an important but also quality of life. So the median survival in patients who have failed is about 14 months. So that's start to be quite limited. So there has to be ways to address that. So how to address the Jakavi failure. So again, there's actually multiple drugs that are being trialed, but in terms of what we have locally, and I think, a pretty judicious choice of a drug is one called navitoclax. So there's some early phase clinical trials have shown that if you use navitoclax, so navitoclax is not a JAK2 inhibitor, it's actually a BCL2, so it's a different target, but BCL2 is actually increased in patients who have myelofibrosis, and it seems that if you target that, you will lead to an improvement in lots of the clinical manifestation of myelofibrosis. So what you see here is a reduction in spleen size in patients who receive navitoclax and Jakavi, and these are patients who have failed Jakavi as a single agent. Okay, so these patients typically you would see the spleen going up in time, and whereas here, when treated with this drug, they seem to get better. And here is reduction in the symptoms as well. So in other words, an improvement. Okay, so that has led to phase 3 study, the Transform 2 study. Okay, so in this trial, patients received either navitoclax or Jakavi versus base available therapy. So these are all patients who have high risk myelofibrosis, who have failed Jakavi, and who have platelets, or they have to have platelets above 100, and they have to have a big spleen. Okay, and the main outcome of this study is quality of life, spleen size, and bone marrow fibrosis. Okay, and this study is available in Ottawa as well as the Jewish Hospital in Montreal. This table here is just meant to summarize what we've talked about. So I just want to point out that this list is not exhaustive. So there's trials open and close all the time. These are certainly most of the trials available at the sites, the Jewish at McGill and at the Princess Margaret and University of Toronto and at the Ottawa Hospital as well. But in a few months, you'll have more trials or different trials. Some will have been closed, some will be open, and some trials sometimes open and close. So that's the nature of things. But, we do, so just to summarize, the airport trial, look at prevention of blood clots using another an anticoagulant called apixaban. The SURPASS trial was looking at pegylated interferon for ET, or essential thrombocythemia. Eclipse was a single-arm study looking at pegylated interferon for PV this time. The ACE 536 study was for lustaprostat, so to increase the hemoglobin in patients who have myelofibrosis. And then the MANIFEST study was when pelabresib was added as a first line for patients with myelofibrosis. Pacifica was using pacritinib, again first line, and then the TRANSFORM was patients who have going to be treated with navitoclax and Jakavi, patients who have failed Jakavi. So there's more trials, like I said, but two that I just want to point out very quickly. They are conducted at Princess Margaret Hospital for relapse refractory patients who have a IDH1 and IDH2 mutation, so they have an investigational drug. And then there is another trial where they look at patients who have accelerated phase or blast phase myelofibrosis using a drug called inacinid. So this is happening in Toronto. So in conclusion, the field of MPN is evolving pretty fast. There's really the drugs that we see now. I think the landscape is going to be very different. We're going to have many more therapeutic options, which is great. There's lots of very dynamic teams of investigators looking for better treatments for MPN. As a patient and advocate, I think it's important to be aware of what's happening, especially at your local site, so you can know what opportunities there is from a patient perspective. So at this point, I want to thank you for your attention. I want to thank Cheryl Petruk to make this happen. Cheryl is a very strong advocate of research and coordinate all sort of very important initiative through the network. Also want to thank Shireen Siram and Dr. Vikas Gupta for provided some information about what's happening in their centers and providing some slides that were helpful for this presentation. So thank you very much.
I'm muted. There we go. So thank you so very much, Dr. Villenueve, for that wonderful presentation that you gave us. Should any of you have any questions from Dr. Villeneuve's presentation, please do put them in the question and answer, and we will make sure that they get to Dr. Villeneuve, and we will pass those answers on to you via our website at www.canadianmpnnetwork.ca. So to keep us on track, we're going to take a 5-minute break. That way you can go to the washroom, get something to eat or drink quickly, and return at 12:15. And that will get us back on track, and then we'll get into our next speaker. So I look forward to coming back to you at 12:15. We have 12:10 Eastern time, so 15 minutes after the hour, wherever you are located. And just before we move into our break, I just want to remind everyone that this recording will be on our YouTube channel within 2 to 3 weeks, give or take a day or two this way or that way, for your viewing pleasure. So if there's something that you've missed during our sessions today, you will be able to view it at your leisure from our YouTube channel. And also, I would like to remind you that we will have a survey for you to fill out at the end of our virtual conference today. So please, the only way we can do better and make better conferences for you, the patient and your care partners and your families, is by your feedback to us. So please do take the few minutes of your time at the end of our sessions today to give us your feedback and fill out the survey. So now we'll take a 5-minute break and come back at 12:16. And we will still be live during our break, and so please do interact with us, and we'll take your questions during that time, and we'll forward them on to the doctors, whether it be Dr. Villenueve or even Dr. Rampal will forward those questions on and get those answers for you. So let's sit back and take a quick break, bio break, or coffee and tea or something to eat, and we'll look forward to seeing you in 5 minutes. All right, I'd like to welcome everyone back to our second half of our virtual Patient Conference today for the Canadian MPN Network. I'd like to thank again our sponsor Novartis for their help and contributions in putting this together for us to make this possible to be an outreach to all of our MPN patients and their families and caregivers and care partners across Canada. I'd like to remind you that our webinar will be posted on our YouTube channel. Look to our YouTube channel and our website at the CanadianMPNNetwork.ca in 2 to 3 weeks, and we'll have this session posted for your viewing pleasure. Also, I'd just like to remind you that we will have a post-conference survey for you to fill out. The only way we'll be able to address issues that you would like to hear about is through your feedback and input to us. So please do take a few minutes to fill out the survey at the end of our session today. So it is with a great deal of pleasure that I introduce our next speaker. This comes, I've taken this snippet from Rate My MD, and this tells me a lot about Dr. Guedes and what I also feel about Dr. Guedes as well, that Dr. Guedes is smart, skilled, and compassionate. Her experience and respect level in the medical community is second to none. Doctors throughout Canada call upon her expertise and knowledge. She's truly a blessing to the Tom Baker Hospital, always educating others as well as herself. Hardworking and always prepared, Dr. Guedes is constantly learning and up to date with the latest advancements. Her commitment, loyalty, and care for her patients is legendary at the Tom Baker, and no patient of hers will ever be left behind. No patient of hers will ever not get the absolute best treatment available. This comes to us from a patient who says she was at the age of 47, or they were at the age of 47, with 2 beautiful children and a loving wife, and was diagnosed with myelofibrosis. He says that my life changed forever that day, and I fell into a very dark place. But eventually I found this doctor who gave me hope. While I didn't expect miracles every time, I looked to Dr. Guedes, and she is giving me the best chance at beating this disease. So with that, I would love to introduce now Dr. Michelle Guedes from the Tom Baker Clinic in Calgary. Thank you so much, Dr. Guedes, for coming on and talking to our patients today and our caregivers. We really appreciate what you do for all of our MPN patients, and I know the Calgary Support Group is very, very happy to have you as one of their own doctors that they call upon.
Well, thank you. That's very, very kind words from that patient. It's kind of embarrassing. So, but thank you very much.
Not at all.
So I've been asked to talk a little bit, an update from what's happening in Western Canada. So I'm just going to see if you can see my screen here. And so I kind of had a feeling when I saw that Dr. Villenueve was going to be an update from Eastern Canada, there will be some overlap here, and there is. So I'm not going to try to repeat everything that he has, except to say that there's a very active MPN community and a very active network of NPN physicians across Canada that are looking to open a lot of quality trials across the country. And so I'm going to talk a little bit about what's available and happening in Calgary and a little bit Western Canada, but I think just to recognize that a lot of these trials are open across the country, and there is a very coherent team across the country. So this is where I'm coming from. So this is the Tom Baker Cancer Center in Calgary. This is a building that was built, I think, in the 60s, and the Cancer Center is the first part of it up to the, I think, halfway through that first taller area, so it's quite small, but this is what's coming next year. There's a new Calgary Cancer Center that's starting, outpatient facility to be open sometime next year. And so we are really hoping to continue to expand our patient care and research protocols here, and doing this in collaboration with our colleagues across the country. And I just wanted to really emphasize that MPN care is, while it can look really nice to have a big cancer center, MPN care is provided many, many places across the province and across the Western Canada and all of Canada in general. And we recognize that we're trying to meet patients' needs in their physicians' offices, in hospitals, in cancer centers, and in smaller centers throughout Canada. So clinical trials are always focused in the research centers. And so, we recognize that there's some of these challenges that happen to people that are relevant for people that live in smaller centers. So we also really rely heavily on our teams from pharmacy, home care, and our caregivers and patient support. And this group itself is really valuable in providing support for patients and caregivers outside of our clinics. So thank you to this support group and its leaders as well. So I just wanted to kind of help people to understand what clinical trials are, because I think there are different kinds of studies that are out there, and it helps to understand what's happened before people go into kind of a big phase 3 trial, and what some of the earlier trials are that are sometimes going to be open to. And I think sometimes people, wonder, are they getting experimental drugs? Are they worried about, they're worried about sort of feeling like guinea pigs? And they also still want to get access to the best treatments that are out there. So just to explain a little bit of the process, what happens with drug development. So generally what happens is people look at potential active drugs in the laboratory and start with animal testing and look for drugs that look like they're effective for certain disorders, but also look like they have a good safety profile. And then they start something called a phase 1 trial. So these trials always go through Health Canada. That looks at safety data, whether this makes sense, that it would be an effective drug. And then the phase 1 trials are small trials, limited number of patients focused on patient safety. So saying, is there any signals that this is an unsafe drug to use? And they start with very, very low doses of drugs, and they'll give, low doses to a set of patients, often kind of below a level where you'd expect to get any clinical benefit, and then increase it, and then increase it. And if you're not seeing any side effects that are coming up that are significant, you're trying to find the best dosing level that we give. And so these patients may be healthy controls, or they may be patients who have the disease that are volunteering to be part of these trials. This is generally small numbers of patients treated with initially small medication doses and increasing up to the therapeutic effect. Then we start getting into kind of trials that we start to pay more attention to. So these are, when we're looking at what kinds of drugs might we think about using, these are phase 2 clinical trials. So this is saying if we have a drug that we think is safe based on the phase 1 studies, and we've got an optimal medication dose, can we do a study where everybody who's on the study gets the drug at the optimal dose? And look at, does this look like it's an effective drug? And so often it'll start off being used in people who've had, disease that's been refractory or has come back after initial treatment. Sort of saying, can we see if this is effective? Does it work, right? And so these are larger studies, often hundreds of patients, and it gives us a good sense as to whether these are effective drugs in different diseases, for these diseases. And finally, you get to the phase 3 clinical trials. So these are large, often randomized clinical trials, hundreds of patients, sometimes thousands, depending on the drug that they're using, where they will randomize patients to either a new treatment or a new treatment combination compared to the standard of care. And this is saying, we think we have a drug, we think it's effective, we want to know, is it better than the standard of care? And this is the big trials that are used to get approval from Health Canada and the FDA to have these drugs available as first-line treatment. So these studies, they will have 2 treatment arms. People are generally randomized by the computer to either the standard of care, which is we think is the best standard treatment, and then potentially the new treatment, which we hope is better. And they will look at a whole bunch of outcomes. So response rates, survival, also quality of life. So it's usually quality of life questionnaires that are important because patient-reported outcomes are huge. We want people to live longer, and we want people to live better, as Dr. Rampal said earlier. And finally, and also safety. So these are larger groups of patients followed for longer, always being monitored for any adverse effects that could come out. So anything that happens on these trials is recorded. And that's why when you see the Viagra commercials, they have 100 different side effects listed, because anything that happens in these trials is listed as a potential side effect. And from that, we will get, you can see on the right, this is response rates to ruxolitinib in the phase 3 trial, where they looked at in the top graph compared to placebo in the bottom to the study drug on the top, saying, you know, what proportion of patients have had at least a 50% reduction in their total symptom score from myelofibrosis. And then the second graph shows, you know, what proportion of patients, what's the cumulative decrease in total symptom score. And you can look at things like comparing symptoms at baseline in the placebo, symptoms compared to baseline in the placebo in blue and in the ruxolitinib arm in the orange bars. So this is where we kind of get our best data. There is a role of a data and safety monitoring committee that goes on throughout trials as well. So this is a committee that is made up of research experts. So it can be physicians, experts in running clinical trials and statistics, and also patient advocates. And this is an independent group that has nothing to do with the study sponsors or study personnel or sites running the trial. So their job is to meet regularly, scheduled times throughout the study, to assess all the data to date, and they're unblinded. They know who's on the study drug, who's not, and they're looking for any evidence of harm, any evidence of adverse events, and also safety signals. And they're also looking to say, should the study continue? Is it obvious that one of these drugs isn't going to be as good as the other one? Or is it obvious that one of them is so good that it's unethical to have people on the other arm, and so you need to put everybody on the better arm? So this is all built into all of these trials. And finally, we have phase 4 studies. So this is once a drug's approved for treatment of disease, there's ongoing safety reporting that happens to Health Canada. It's continually conducted, and this is where you can look for rare side effects. You know, once you have thousands of people that have been treated, you might find evidence of some rare things that we didn't know about early on. So this is what happens in this process. So I'm giving an example of Alberta because that's where I am, but I think this is a very Canadian issue, and I'm just using Alberta as an example for this. We have specialized centers that have hematologists in a few centers in the province, and a lot of people that live very far away. So we have hematologists in Edmonton, in Calgary, in Red Deer, in Lethbridge, and large areas of space where distance is a big barrier for patients. And I think in Ontario and Quebec, that's true as well, although there are more community centers that are available with hematologists. And I know in BC, it's a big issue as well, and in Saskatchewan and Manitoba. So, and this is an example of a balmy Alberta November day. So this is I was doing a talk about an oral agent that's coming out, and we're looking at how we try to manage, you know, drugs where people have to come in for IVs every day. And this is a big issue for people who have to travel and come for patients or come for clinical trials, especially that require more clinic visits. So this is a list of some of the open clinical trials that we have here. And I think as I was going through this list, almost all of these were already brought up by Dr. Villenueve. So I'm going to just mention them briefly, but I'm not going to spend a lot of time on these. I just want people really to raise the awareness to say, you know, these studies are available in multiple centers across the country. So contact your physician and find out if it's available at your site. If this is something that you're interested in, I'll run through what we have going in parts of Western Canada. So Dr. Villenueve mentioned the airport trial. So this is comparing patients with higher risk for thrombosis. So patients with polycythemia vera who have essential thrombocytosis and a JAK2 mutation, or prefibrotic myelofibrosis that's JAK2 positive. And we know that this is for patients that are newly diagnosed, but also patients who have been diagnosed years ago. If you've been diagnosed 5 years ago and you want to be part of this trial, you could be enrolled in this. We know that patients are at increased risk of both arterial and venous clots, and that risk is about 2.5% per patient year. So for every year that people have myeloproliferative neoplasm in this risk category, about 2.5% of people will have a blood clot. So that means that at 2 years, about 5% will have had a blood clot, and 3 years, about 7.5%. So that is a substantial risk. And we know that this is true despite the fact that in the studies that looked at this, about over 80% of patients were on aspirin. And so we know there's a reduction in thromboembolic events on aspirin, but it's not huge. So we're trying to sort of say, can we reduce the risks of clots further with low dose apixaban, which is an anticoagulant. And so, as Dr. Villenueve said, this is assessing feasibility of the randomized controlled trial, and they're looking at recruitment rates, whether it's feasible, rates of arterial clots, venous clots, deaths, and related to blood clots, and also bleeding risk when you put people on anticoagulation. So this recruitment is ongoing, and it's happening in multiple sites across the country, and the aim is to expand it globally. So they've just applied to a Canadian Institutes of Health Research grant last week to apply for funding for expanding this trial. Dr. Villenueve mentioned the Independence trial, which is a trial looking at a growth factor called luspatercept for red cells in patients who have myelofibrosis and are on ruxolitinib but have anemia. So we know that ruxolitinib is a very potent drug in myelofibrosis, but it can make the platelets in the red cells go down. Some patients will have better symptoms despite the fact that they're more anemic, but some patients will become transfusion dependent, and that's a big problem. So this is looking at patients who are transfusion dependent and comparing a luspatercept injection every 3 weeks to placebo, and looking at how many patients can become transfusion independent or reduce their hemoglobin. So you can have had erythropoietin before, but just not in the 8 weeks prior to the study. So how does luspatercept work? This is a fairly new drug that has been developed and is approved for use in myelofibrosis, which is another bone marrow failure disorder, as well as some inherited hemoglobin problems like thalassemia. And so this binds to members of the TGF-beta superfamily. There's a pathway, the SMAD2/3 signaling pathway, which looks like it suppresses some of your red cell production in the bone marrow, and this interferes with that pathway suppressing the production. So it's interesting that if you look at how this works, we know that erythropoietin, which is a growth factor made by the kidneys to produce more red cells, happens early in the development of red cells, and the luspatercept works later in the development of red cells. So it's a very different mechanism of action. There's a good success rate in people who've not responded to erythropoietin in other diseases, and so we're hopeful that this will also pan out in myelofibrosis and improve symptoms. So again, as we talked about, we're looking at improving red cell function, but they're also looking at survival, iron overload, quality of life, anemia-related symptoms, and also healthcare utilization. So are people in the hospital more? Are they going to appointments more? Those kinds of things. So Dr. Villenueve mentioned the BET inhibitors, and so this study is also open in sites in Western Canada. So in patients with previously untreated myelofibrosis, and it can be out of the blue, or it can come out of an underlying polycythemia vera or central thrombocytosis. It can be randomized to either ruxolitinib plus a placebo or ruxolitinib plus the BET inhibitor, the pelabresib. So we're hopeful that this will improve response rates to just single therapy with ruxolitinib alone in these patients. So there's a 1-to-1 randomization. So people enroll in the trial, the computer does a randomization, and you either get placebo plus ruxolitinib or you get the study drug plus ruxolitinib. You don't actually know which one you have, but there is a crossover. So if you get to 24 weeks, so 6 months out, and you have progression of your disease, so it's getting worse, and you turn out you're on the ruxolitinib plus placebo arm, patients can then go on to the treatment arm. So everybody that can then go on to the ruxolitinib plus the BET inhibitor arm. So it does offer a good treatment option for people, and it's a good thing to think about for people who are newly diagnosed. And again, they're going to look at quality of life and whether you actually reduce the bone marrow fibrosis. The Pacifica trial is also open in Western Canada. So it's open in Calgary, it's open in Vancouver, I believe in Edmonton as well. I'm not sure about Saskatchewan. So this is, again, pacritinib, which is a JAK1 inhibitor, not a JAK2 inhibitor, that looks like it's effective in patients who have low platelets without making their platelets lower. And that's a big problem as in patients who are on ruxolitinib. If you start off with low platelets, it's very hard to treat that without making the platelets worse. And ruxolitinib is not approved for patients with platelets under 50, although we do use it at times. So this is a 2-to-1 randomization. So for people who people have actually a 2/3 chance of getting the study arm and a 1/3 chance of getting the physician choice, which could be something like standard care, like transfusions or low-dose ruxolitinib, for example. So this is the clinical trial. So people who've already been on treatment before, if you've had 90 days of ruxolitinib already, we can't actually put you on, unfortunately. But they're going to look at total symptom score, spleen size, quality of life, and safety, as well as survival. As well, for patients progressing on ruxolitinib, this is a molecule that Dr. Rampal mentioned. I don't think Dr. Villenueve mentioned this study specifically, but there are inhibitors, small molecule oral medications called MDM2 inhibitors that bind to the MDM2 protein and look like they may be effective in patients who have a particularly troublesome mutation with a TP53 abnormality. So we know this is an adverse prognostic factor in patients with myelofibrosis, and it tends to make people resistant to other therapies. Disease tends to progress faster, and cells are resistant to dying off naturally or having apoptosis. So this is a new novel mechanism of action, and there's a phase 3 trial for patients who are progressing on ruxolitinib, randomizing them to the KRT 232 versus best supportive care. And patients can have had fedratinib as well. So if you have progressed on that, this is a potential treatment option for people without a lot of other good options right now. And finally, just to mention a little bit about stem cell transplant. So transplant is really reserved for patients with higher risk myelofibrosis, people who've had significant life-threatening complications of their myeloproliferative neoplasms. And that's because although it's our only curative option, it also does have quite significant risks with it of treatment-related morbidity and mortality. And so also a lot of our patients are older, especially with myelofibrosis, and may not be able to tolerate a transplant very well. And so Dr. Villenueve mentioned the AlloBat study. This is a very interesting study. They're looking at sort of feasibility and doing it in several centers across the country. But hopefully this can also be expanded into a larger study. And this is, again, a Canadian initiated trial. And so this takes patients who have high risk myelofibrosis who are eligible for transplant, so otherwise fairly fit and healthy patients, and compares them outcomes if we do stem cell transplant versus best available therapy. And transplant's a very personal decision. Not many people are willing to just be randomized to have a transplant or not. This is the decision people make based on their goals and their values. And so this is not a randomized trial, but it's based on patient preference. So they're taking all patients who are being offered a transplant because of their disease status and their otherwise physical fitness, and they're enrolled before they make a decision whether to proceed to transplant or not. And then what we do is just kind of follow outcomes and see what happens. So this is for people who have high risk disease, and we talked about some prognostic scores. People mentioned before the DIPS, Dynamic International Prognostic Scoring Scale, which looks at a number of different features of the disease and patients to say, do we think this is disease that could behave badly, or do we think it has a low risk? And there's a molecular IPSS-70 and a version 2 now that we can use all these NGS gene mutations and plug them in as well to help assess risk. And we know people have a TP53 mutation that's high risk. So patients are enrolled. They're looking at the feasibility of doing this, of doing the study based on just patient preferences. They're also looking at the proportion of patients who go through this process, who go on to transplant versus who decide to continue with non-transplant therapies, and what are the factors associated in this decision. I think this is a very big decision for many people. And they're going to look at longitudinal symptoms over time, both in the transplant arm and the non-transplant arm, quality of life, survival, relapse rates, and patient-reported outcomes. This is a really, really interesting and neat study, and I hope we get some good outcomes out of that. So people who are being considered for transplant, this would be something that'd be nice to be involved in. So this is open in Calgary, Edmonton, I think Toronto, Montreal, I think other centers across the country as well. And then trials that are coming. So Dr. Rampal mentioned rusfertide. So this is a Herceptin inhibitor that has been used in patients with polycythemia vera. So this inhibits a molecule that normally tells your bone marrow to make more blood cells, basically. And so this is a way of trying to reduce the hemoglobin without putting people on phlebotomy. So you're not trying to necessarily make them iron deficient. And they talked about a little bit of that risk of pulmonary fibrosis, pulmonary hypertension, and the heart has to work hard all the time because you're dropping your hemoglobin regularly. So also this doesn't reduce your platelets and white cells the way that hydroxyurea does. So it's a very interesting trial. They did a phase 2 study. So that's where they give everybody the drug, right? And they had, I think, 63 or 64 patients in that arm, and 84% of the patients needed no phlebotomy. So this is a very promising drug, and this is coming to clinical trials as well. And then the issue of how to get access to interferon is really important for Canadian patients, especially. So we don't have ready access to most pegylated, so long-acting interferon that lasts for like a week, or the Ropeg, which is the 2-week long interferon injections. And so they're opening a transport trial, which is for patients who are already on pegylated interferon, because we are losing some access to that across the country, to transition them to Ropeg interferon, and that's with support of the drug company that makes the Ropeg. In MPN patients already on treatment. But as Dr. Villenueve mentioned, there are 2 trials that are opening in Calgary. I think they're opening in Vancouver as well, and potentially other sites where patients will be able to access Ropeg interferon even if they haven't had any interferon before. So this is for patients with polycythemia vera and the essential thrombocytosis respectively. So this opens it up to new treatment options for patients that we currently have difficulty getting access to in Canada. These are trials that are currently open in Vancouver. So they also have the luspatercept trial, the pacritinib for patients with low platelets and myelofibrosis, the PEG interferon trial for the essential thrombocytosis they have open already, and the BET inhibitor trial as well. So other things that have been happening is the MPN Genie app is now available for patients to track symptoms. And I think that you're going to get a little bit of an introduction to the Genie app later for those who haven't. And then finally, just some information about the Canadian MPN group. So right now that website is down, but it should be hopefully up and running once some technical issues have been cleared with that one. Also, just updates from the MPN network across Canada. So I'm presenting this information and on behalf of my colleague, Dr. Sonia Sarkozy, who's also the principal investigator on most of our myelofibrosis trials in Calgary and has been quite involved in the MPN groups across the country. So Dr. Shireen Sirhan from the Jewish Hospital in Montreal took over from Vikas Gupta from Princess Margaret over the past year as president of the Canadian MPN group. And there's some newer executive members that have joined, including Sonia Sarkozy in Calgary, Dawn Mays in Toronto, and Natasha Suber in Montreal. There is a Western MPN conference that is attended by physicians, pharmacists, and other healthcare workers every 2 years. And the goal of the Canadian MPN group is to expand this actually to a national conference. And there's also some retrospective studies that have been going on through the Canadian MPN group, including projects specific to adolescents and young adults. So patients under the age of 40 who have MPNs. You know, this is a different group of patients, as one of our questions alluded to earlier. And perioperative management. So how do you manage patients who are on all of these drugs or have high platelets around surgery? And we know the increased risk of clotting and bleeding is there. And they're hoping to establish consensus guidelines for across the country to help guide physicians in managing these disorders. And they have already produced one, which is a pattern of ruxolitinib failure and its management in myelofibrosis, so perspectives of the Canadian MPN group. And that one is available online. So with that, I did not take as much time as I was allotted, but I think some of this information has already been included by or presented by Dr. Villenueve, and really want to just try to increase awareness that these are trials available across the country, and always recruiting, and you're welcome to come and talk to your physicians about those and about all of these things if you have any interest in being involved in trials in your care.
Thank you so very much, Dr. Guedes. We do have actually some questions for you. So this is not directly related to your talk, but the asker of this question is interested in your opinion of the importance of next generation sequencing, or NGS, for all MPN patients. And is there progress in Canada to make this standard of care?
So that's a really good question. It depends where you live in Canada. So the access to this is controlled by each of the provincial governments. So for myelofibrosis, I think it's pretty standard of care to have access to next generation sequencing testing at the time of initial diagnosis. And so that is not a big issue for most patients across the country. Whether to do it again later in the course of treatment, that is less clear. And most of our prognostic scores were really designed to be testing, giving this information at the time of initial diagnosis. But we certainly do use them again when we're trying to talk to patients about, for example, whether transplant is a good option for them, because diseases do change over time. So for the other myeloproliferative neoplasms, so for essential thrombocytosis and polycythemia vera, it varies a lot. It provides prognostic information for sure, and I think there's no difficulty getting testing for JAK2 across the country, MIPL, CALR, some of these important ones. To get a full NGS panel in Alberta, we have to ask for it for patients who are not myelofibrosis patients. And I'm not sure that it's available for those disorders for those across the country. And so right now it's providing prognostic information. It would be great to have, especially for patients where you would think about more aggressive treatments like transplant, or if you have access to things like interferon and you're thinking about using that in patients who have a high risk of progressing, for example, with polycythemia vera or ET.
Excellent.
So it's important. It's not universally available for ET and PV. We can get them on, most places will give them on special request, but not every center. And I'm not sure if it's available in Ontario right now.
Wonderful. Excellent. Thank you. So our next question comes from a patient. I'm on 45 mcgs of Pegasus every 4 weeks, and that's where my counts are all stable. I would be concerned about how Ropeg interferon would work for me. So I guess the transition from pegylated or Pegasus to Ropeg, Dr. Guedes, what is your feeling about that?
So probably like any drug, there'll be a little bit of trial and error. So if you are on full dose, I imagine they would transition to full dose. If you're on reduced dose, you probably start on a reduced dose of the Ropeg. And you can start on lower doses and build up too, and we do that with a lot of our, non-pegylated interferons, just to ensure that tolerance is there. So sometimes we just have to adjust the dose as you go along. So you can extrapolate. So if you needed a dose reduction up until now, I expect that if you start on Ropeg, that you would probably be on a dose reduction as well. But it's essentially the same drug. It's just a longer acting version, basically.
Excellent. Great. And our other question that comes to us is, how will you compare Jakavi and interferon treatments? They're two different mechanisms of actions. And how do you compare the efficacy of those?
Yeah, so for myelofibrosis, it's different than for polycythemia vera. For myelofibrosis, ruxolitinib or Jakavi, it has the big phase 3 trial. We see a survival benefit not because patients have less fibrosis or less transformation of acute leukemia, but really, probably because patients are healthier. You have less weight loss, less sweats, stronger, less chances of other infections and other things causing significant problems. So for myelofibrosis, other than the very early patients that Dr. Rampal referred to, we generally would just go with the ruxolitinib. For polycythemia vera patients, that depends probably partly on the age of the patient, whether there's already some fibrosis happening. I think if there's some concern about fibrosis, that might be patients where we're a little bit more concerned, might be more trying to push the interferon, especially early in the course of the disease, compared to the ruxolitinib. But there is also a side effect profile. So interferon, these pegylated ones are easier to tolerate than the short-acting ones, but they still do have significant side effects to them. And probably more than the ruxolitinib does in terms of some of the adverse effects related to it. So I think that's all part of the discussion that you have with your doctor. And right now, to be honest, interferon access is challenging. So ruxolitinib is better. And please excuse my dog.
Well, we look forward to getting the interferon trials, concluded, so that the efficacy can be shown and that it becomes much more available for our MPN patients, for sure. Excellent. So we don't have any more questions, it doesn't look like, that are coming through. But if you do, folks, if you do have any questions, please do still send them on, and we will get Dr. Guedes to answer them and post them on our web, and we'll post them on our website for your knowledge after the conference, the virtual conference, is over. So with that, Dr. Guedes, thank you so very much for attending. It is a real pleasure to have you with us. And I know the Calgary Support Group is very, very thankful that you are one of their champions for them. I'd also just like to reference the group that Dr. Guedes talked about. MPN Canada is the doctors group here in Canada. So we work very closely together with MPN Canada, the Canadian MPN Network, and the Canadian MPN Research Foundation, working together for all of our patients and families in Canada. So very much an integral part of all of our working for the entire community. So thank you very, very much again, Dr. Guedes, for your informative and inspirational talk today. Thank you so very much. All right, so now we'll be moving on to an update from the Canadian MPN Research Foundation, and I'll talk a little bit about our latest application for you, the patient community, to be able to use in your journey with MPN, with an MPN blood cancer, whether it's PV or ET. So we'll bring up the slides for the MPN Genie. And now I'd like to take you on just a quick tour of what the MPN Genie is all about. It's a quality of life tracking tool application that you can download, that the patient can download from the Apple Store or from the Google Play Store as well. So next slide. So the MPN Genie really is about helping the patient, the research community, and the physician through patient empowerment, physician knowledge of the longitudinal data of the quality of life that a patient is having, and also helping the research community through aggregated, having access to the aggregated and anonymized data that we will be utilizing from the app. So it's really a very powerful tool in helping the patients have a better quality of life, in empowering them to know and understand what their quality of life symptoms are and how they're living with them on a daily basis. Next slide, please. So the MPN Genie quality of life app, well, through the patient empowerment, you, the patient, are documenting the burden that the disease has on your quality of life. And this will provide your MPN physician, as well as perhaps your GP physician, the opportunity to see a holistic view of the patient and not just a moment in time. So many of you, when you go to clinic, you will fill out the MPN 10 prognostic scoring indicators at the time of your clinic visit. Well, that's only giving your physician a very quick picture of a moment in time of how you were feeling and how you were doing as in your quality of life in your journey with an MPN blood cancer. And it's really only looking at that moment or that picture in time. So the app will give your physician the opportunity to see the longitudinal view or perspective of the quality of life that you're having over a period of time, perhaps from clinic visit to clinic visit. And the data, the aggregated and anonymized data, will help the research community and provide them the opportunity to see data to help with new and ongoing research initiatives and to help investigate new therapies for MPN blood cancers. Next slide, please. So this is a picture of what the app would look like if you log into it from your phone or your tablet. You'll have to put in your email, create a password. You'll have to put in some demographic information about yourself. And I want to let you know that this information stays with you on your phone or your tablet. Really, the Canadian MPN Research Foundation, who owns the app, doesn't get the data that is your data, but we do see aggregated and anonymized data, and we do have your email address, but we don't have your password or those details as well. So we just have a very high level of who has accessed the app and who is utilizing the app. Next slide, please. Again, these are just screenshots of when you create your account, what you'll be asked to participate with as far as personal data. And then you'll get a verification email to establish, saying that you've established your account and you can now log in and go ahead and start using the app. Next slide. So on the prognostic scoring indicators, these are the MPN 10 questions that you would, as a patient, answer during your clinic visit. So here now you have the opportunity to answer these questions on a weekly basis, and you have the ability to either use the toggle switches, the arrow, the plus or minus arrows on either side, or utilizing your finger to scale across the numbers at the bottom. Then the data is all captured on your phone or your tablet and stored there. You do have the opportunity, as you can see the circle, to change your scoring if you so choose to after you go in and answer the question. And in this case, we've circled the fatigue. So if you think that your fatigue is at a 3 and then you decide you want to change it later, you do have the ability to go back and change it. At the bottom, it will give you your total MPN 10 score to give you an indication of where you're at with the prognostic scoring indicators. And these are the things that the doctors will look at your clinic visit in trying to assess your quality of life and how it is the burden or a non-burden that it is affecting your journey with an MPN blood cancer. Next slide. Again, the app will give you some information and it will show you your longitudinal data in a statistical form, in a graphical form, so that you can see how you are progressing or how stable your quality of life is with the longitudinal aspect of tracking of the quality of life prognostic scoring indicators of your journey with an MPN blood cancer. We do also ask some other questions, some qualitative questions that we would like to find out, that researchers and your doctors would like to find out from you. And those are asked in the other areas of the app. And typically the questionnaires as from the MPN 10 and the other questionnaires will take approximately about 20 minutes to answer all of those questions on a weekly basis. And when we put the app together, we asked patients what they would like to see on the app, what they would like to share with their doctors, as well as we've asked our Canadian MPN doctors what they would like to see, as well as we had the opportunity to ask global doctors across the globe, across the world, how important looking at longitudinal data is. And they've all come back to us saying very, very important. So I can tell you that we have interest from American doctors wanting to look at the app and perhaps utilize it for their patients. I have global doctors from the UK, Spain, Germany, who are inquiring about the app, and we will be globalizing the app so that the entire global MPN community can be using this app to track their symptoms, their quality of life, and the burden that the disease has on their quality of life and how they live on a daily basis with the fatigue and other symptoms that might be had by themselves in the living with the illness. So it's important for you as MPN patients to have the empowerment to track your quality of life symptoms. Important for your doctors to be able to see the longitudinal data and correlate it to the clinical blood numbers that they get from your blood work, and be able to have a very holistic view of your journey with an MPN blood cancer. So here on this slide, you can see your profile. It gives you your name. It will give you your email address that you've signed up with. It gives you the opportunity to change your login credentials should you want to. And it also gives you the opportunity to put in your notification preferences, because the app will tell you when you need to fill it out the next time. It will come up, saying, hello, Helena, you need to fill out your app this week, or thank you for filling out your app this week, Helena. If you have any questions, we'd love for you to hear from you. Please do email us at the mpngenie@cmpnrf.ca. We'd love to hear your feedback. We've gotten such great feedback already. We will be making some changes and additions to the app by adding extra questions or more questions that patients have given to us and that our doctor community has said they would like to see. So we will be adding and making the app a little more robust over the next period of a couple of months. And then prior to our expansion to a global app, we will be having the app translated into 3 global languages to start off with. Currently, we have the app in both English and French to meet the needs of our French Canadian population. And we will be then going in the globalization for the first round of globalization to Spanish, German, and Italian, and perhaps a Slavic language and Taiwanese, as we've had interest from both Taiwan patients and Slavic countries as well. So we will be including that. And then going in our next globalization expansion, we will be going to other global languages to include them. Next slide, please. So this is a doctor's view of the app. What the doctors will see, they will have a portal that they log into, and they will be able to see your data that you put into your app. So I encourage each of you to talk to your doctors about utilizing the app and sharing your knowledge with them on the app so they can see your information prior to your clinic visit. One of our future goals is that currently the doctors would be able to print off a PDF version of your results from your tracking of your quality of life symptoms. We want to, one of the futuristic goals is to be able to have the doctors to have a button or an opportunity where you see the option button at the top of the right-hand corner for them to upload your information into your electronic medical records or your EMR. So that's already futuristic for us, or the next step in the evolution of the app. So next slide, please. Again, this is an overview of what your doctor will see on a graphical and qualitative analysis of your MPN 10 scores and your qualitative analysis scores. So they have this right at their fingertips to be able to view it prior to your clinic visit and then be able to discuss it with you at your clinic visit. Next slide. Again, this is the PDF of what the doctor will see, and it shows over time. They can choose the time. They can choose the oh gosh, I'm lost for the word, for the MPN 10 prognostic scoring indicator individually. They can choose that to see the trend or the longitudinal data holistically or by prognostic scoring indicator. Next slide, please. And this is a PDF version of the qualitative answers that you provide in the quality of life, other symptoms area of the app. Next slide. So for more information or how to register for any upcoming patient webinars that we'll be having for our MPN Genie training, please visit our website at the Canadian MPN Research Foundation at www.cmpnrf.ca. And we'd love to do one-on-one webinars for you or group webinars. And certainly there's not anything that we can't provide information on or help you, guide you through getting registered for the app for you to be able to use it. It's really, we feel, a benefit for our patient community, a benefit for our physician community, and definitely a benefit for our research community to see the aggregated and anonymized data. So that's a little bit about what we're doing at the Canadian MPN Research Foundation. Watch our website for more information, and we look to helping to support research projects in the upcoming future of 2022, and those initiatives will be announced shortly, probably towards the end of September, beginning of October, for our request for grants and to be able to fund some of those grant requests in Canada for MPN research projects. Excellent. So now on to our, we'll just go over a brief review about the MPN champions. So if we could bring those slides up. So the Canadian MPN Network has a wonderful program called the Canadian MPN Champions. This is your opportunity to nominate someone that you feel has gone beyond the call of duty or who contributes to the MPN community here in Canada. And we have an award that is given out to deserving individuals. So we would forward you to our website, the CanadianMPNNetwork.ca, to find the nomination form and nominate your MPN champion. If you go to the next slide, I'd like to make special comment on our past champions, Dr. Vikas Gupta, Mr. Tony Comper, Mr. Ed Pascal, Mr. John Clark, Ms. Joanne McKinley, Mr. Simon Lono, Mrs. Karen Arner, Dr. Elena Liu, Dr. Sonia Sarkozy, and Dr. Michelle Guedes, who have all been past recipients of the MPN Champion Award here in Canada. So with that, I think we are on track. Let me just check my notes here where we're at. I think we're a bit ahead of schedule. And at this point, what we'll do is we'll just take a 2-minute break to regroup and get our next set of slides up and come back to you in just a moment. All right, welcome back. So we're just a bit ahead of schedule, so we just had to make sure that our next area is up and ready to present. I did want to apologize and say I forgot to add our latest award winner from our MPN champion last year, Doug Chisholm, our support group leader from Southern Alberta. So my apologies to you, Doug. On that. So I did have there are a few questions regarding the MPN Genie. And one is, why isn't my doctor listed? Certainly, please do let us know. Send us an email to mpngenie@cmpnrf.ca and let us know who your doctor is. And we will send an invitation out to your doctor to get them to subscribe to the Genie application. And but certainly you can use it without connecting with your doctor on the actual when you set up your account. So you can use the Genie app without setting up your doctor, and certainly we send us an email and we'd love to get your doctor connected on the physician side. So please do send us an email on that. I'm just going to check if there's any more questions. So there's no further questions on that. I am just going to check my running notes here if there's anything else that we need to address. And yes, absolutely. I just want to again let you know that we will be directing you to a survey once the webinar has ended. You will be directed to a survey whereby you'll be asked a few questions to help us plan our next conference to your liking and to topics that you would like to hear and hear on, and representatives for those topics. So certainly please do fill out the survey. That's how we get greater benefit and better opportunities for our speakers, and to provide you, our audience, with better information about your disease diagnosis. So with that, I would now turn it over to our next section, and we will be, as we are a little bit ahead of time, we will be finished sooner rather than later, which I think everybody will be happy with. So now we'll run to the next set of slides, and then after that, we'll hear from Patty Salak, one of our board members. So now, without further ado, I'd like to introduce Patty Salak from Edmonton, Alberta. Take it away, Patty.
Thanks, Cheryl. Good morning, everyone, or afternoon, wherever you might be. Thank you for attending our September conference. My name is Patty Saluk, and I am one of the newest board members of the Canadian MPN network. I'm also the coordinator for the Northern Alberta MPN support group. I'm here today to speak to you about volunteering for various positions on the board and become part of the decision-making process that pertains to your MPN. Currently, we are looking for new board members. I joined the board after the provincial group coordinators were invited to the board meetings, and I found the information I was gaining so useful. After attending a few monthly board meetings, the board asked if I'd like to join and be part of it, so I accepted. By doing this, I now have a voting privilege on the board decisions about my MPN. The Canadian MPN Network is an active group that works to improve your and our quality of life. We advocate for the governments, or to the governments, to provide approved medications at no cost to patients. Our advocacy committee worked diligently to get COVID-19 shots earlier because of our medical conditions, and we were very successful. The board has also been successful in establishing a communications committee that not only produces a newsletter twice a year, but also a more in-depth website for you to locate updated information. The board gives myself as a group coordinator direction and guidance as to how to help you and your care partner. There are not a lot of extra commitments to joining the board either. Of course, it is expected that you are part of one of our support groups across the country. Also, you should attend board meetings regularly. Currently, we meet monthly, but we're exploring meeting bi-monthly. Also, if you're a board member, it's expected that you sit on one of our committees. For example, this could be this conference committee or advocacy committee, which some of us already are. Becoming a board member also opens the option of attending larger and international conferences. Board members are the ones typically extended the invitations with the costs paid for. This year, I will be representing the Canadian MPN Network at the Horizons Conference in November in Israel. All of the meetings are via Zoom as they encompass members from across Canada, and the time schedule for the meetings take this into account. Being on the board is also open to our care partners. As you know, our care partners sometimes know us better than ourselves, so though their opinions matter to make our quality of life and theirs better. And we currently have this situation on the board. So this is just a little bit of what the Canadian MPN Network Board does. I hope that I've enticed you and gained your interest in becoming one of our new board members. And if you feel that joining the Canadian MPN Network Board is a little overwhelming, why not join one of our committees I've mentioned and get your feet wet, as they say? You can contact your support group coordinator or contact us at www.canadianmpnnetwork.ca. Thank you again for attending our conference. Hope you have enjoyed it.
Thanks so much, Patty. And I can only reiterate what Patty has said. I hope each and every one of you have gained some new information from our doctors, our wonderful doctors, Dr. Rampal, Dr. Villenueve, and Dr. Guedes. We hold each of them in high esteem because they truly have the best interests of their patients, and they're so very knowledgeable about MPN blood cancers that we really do hold these doctors in very high regard in each of our countries. So, and across the world, all three of them are internationally recognized as well. So thank you to each of them for coming today and speaking with you, and to our conference committee. Joanne McKinley and the other names that were listed on your screen. Thank you so very much for putting on and organizing a wonderful conference today. So again, I'll ask you, you'll be directed to fill out the survey. You'll be directed there shortly when our webinar finishes. So please do fill out the survey as we look to get your feedback. Remember to check out YouTube in a couple of weeks on our YouTube channel and to watch this conference there in its entirety. And I believe we will be having it both in English and with French subtitles. So our French Canadian community can watch the conference as well. So please watch our website for our February conference that will be coming up. We hope to have some different topics presented to you and different formats, perhaps a panel discussion or a patient story for you to hear and enjoy listening to and gaining more information. So thank you very much to the Canadian MPN Network. their board of directors, and all their committee people for doing what they do in making a difference in the lives of MPN patients. With that, I believe we're almost a little bit ahead of time, but right on schedule. So I wish each of you a wonderful day, no matter where you are in Canada. Have a great day and a great rest of the weekend.